Good morning everyone, we are the group 2 and today we are going to discuss calcium channel blockers. So first of all, what is calcium channel blockers? So calcium channel blockers are a class of medications that work by preventing calcium from entering the cells of the heart and the blood vessels. Since calcium plays a key role in a muscle contraction, blocking it leads to relaxation of the blood vessels and reductions in the heart workload. The main purpose of this drug is to treat various cardiovascular conditions. They help in lowering blood pressure, relieving chest pain or angina, and managing irregular heartbeat.
The therapeutic actions of calcium channel blockers is first is inhibit the influx of calcium ions through L-type calcium channels in cardiac smooth muscle cells. Second is cause vasodilation of peripheral arteries, reducing systemic vascular resistance and lowering blood pressure. Third is decrease myocardial contractility, negative inotropic effect. Fourth is slow down heart rate by affecting the sinoatrial and atrioventricular modes, negative inotropic and thermotropic effects. Last one is reduce myocardial oxygen demand while improving oxygen delivery by dilating coronary arteries. Indications of calcium channel blockers. First is hypertension, especially effective in older adults and African descent populations. Second is angina pectoris, chronic stable angina, variant pituitary angina. Third is supraventricular arrhythmias like atrial fibrillation and paroxysmal supraventricular tachycardia, mainly with non-diaphragmatics like verapamil and vitreoset. Fourth is Raynaud's period, to relieve vasoconstriction. Fifth is migraine prophylaxis. Sixth is hypertrophic cardiomyopathy, to reduce outflow obstruction in specific cases. Last one is prevention of later of liver use.
Next, I will explain the mechanism of action of calcium channel blockers or CCBs in the human body. Calcium channel blockers primarily work by inhibiting the influx of calcium ions through specific structures called L-type calcium channels. These channels are located in two important areas: the vascular smooth muscle, which lines our blood vessels, and the cardiac muscle cells, which makes up the heart. When calcium enters these cells normally, it triggers muscle contraction. However, when blocking these calcium channels, CCBs cause muscle relaxation instead. This action produces three major effects. First, relaxation of vascular smooth muscle. This leads to vasodilation or widening of the blood vessels, which significantly reduces blood pressure. That is why calcium channel blockers are often prescribed for hypertension. Second, it reduces myocardial contractility. This is called negative inotropic effect. It means the heart contracts less forcefully, and as a result, the heart doesn't have to work as hard, which helps decrease its oxygen demand, especially useful in conditions like angina. Third, slowing down of conduction through the atrioventricular node occurs. This results in a decrease in heart rate, known as negative chronotropic effect, and is mainly seen with specific types of CCBs called non-dihydropyridites. So for the summary of the end results, overall, calcium channel blockers lowers blood pressure, reduces heart rate in some cases, decreases cardiac workload, and improves oxygen delivery to the heart.
Calcium channel blockers are divided into two main groups. The first group is called dihydropyridines. These drugs mainly act on blood vessels, causing them to relax and widen. This helps lower blood pressure. Examples of dihydropyridines include amlodipine, ephedrine, and felodipine. The second group is called non-dihydropyridines. These act more on the heart itself. Non-dihydropyridines are further divided into two types. First, the phenylalkylamines like verapamil, which means they slow down the heart rate. And second, the benzodiazepines, like diltiazem, which affect both the heart and blood pressure.
For the contraindication, first is very low blood pressure or severe hypotension. CCBs lower blood pressure more, which can be dangerous if it's already too low. Next is second or third degree AV block without pacemaker. CCBs slow the heartbeat. If the heart's signals are already blocked, it can make it worse. Next is sick sinus syndrome. The heart's natural pacemaker doesn't work well. CCBs can slow the heart too much. Next is acute myocardial infarction or non-dihydropyridines. These CCBs can weaken the heart during a heart attack, making it worse. Then last is heart failure with reduced ejection fraction. Some CCBs make it harder for a weak heart to pump blood.
So now moving on with the adverse effect. First one is the central nervous system. You might feel dizzy or lightheaded. You could also get a headache or feel very tired. Next, there can be also stomach problems. You might feel nauseous or sick to your stomach. Your liver could also be affected. There are also heart and blood problems. First one is that you might have low blood pressure. Your heart could beat slower than normal. Lastly, you could also have a swelling, usually in your ankles or feet. So finally, you might have some skin reactions. So in here, you could also notice flushing, which means your skin might turn red or feel very warm.
First, for drug-to-drug interactions. All calcium channel blockers have varying drug-to-drug interactions. One important interaction to remember is that when diltiazem is combined with cyclosporine, it can cause an increase in cyclosporine toxicity and raise its serum levels, posing serious health risks. Additionally, verapamil and diltiazem can reduce the elimination and increase the blood levels of certain drugs like your carbamazepine, simvastatin, atorvastatin, and lovastatin. This can potentially lead to drug toxicity, so careful monitoring and possible dosage adjustments are necessary when these medications are used together. Now for drug-to-food interactions. Patients should be advised to avoid grapefruit juice. Even just one glass, approximately 200 ml, can significantly increase the serum concentration of calcium channel blockers. This heightened concentration increases the risk of toxicity. Some examples of calcium channel blockers affected include verapamil, felodipine, nifedipine, nicardipine, nisoldipine, and possibly amlodipine.
So now let's talk about the assessment before administering calcium channel blockers. First one is to check for blood pressure. So why do you have to check the patient's blood pressure? CCBs lower blood pressure. Therefore, giving them when their PP is already low can cause hypotension. We have to hold the medication if systolic blood pressure is below than 90 mmHg or per protocol. The second one is the heart rate. We have to check the patient's heart rate because non-dihydropyridines or verapamil or diltiazem slows heart rate. Therefore, we have to check for bradycardia and hold the medication if heart rate is less than 60 beats per minute unless directed otherwise. The third one is to check for the patient's cardiac history. So why do you have to check the cardiac history of the patient? Conditions like heart block or heart failure may worsen with calcium channel blockers. Therefore, we have to review history for AV block, sick sinus syndrome, or congestive heart failure. The fourth one is to check for the patient's liver function. CCBs are metabolized by the liver, and impaired function may affect drug levels. So the action is to monitor liver enzymes and adjust dosage if needed. The next one is to medication interactions. So, CCBs interact with beta blockers, digoxin, and grapefruit juice. We have to check for interactions to avoid additive effects such as bradycardia or toxicity. Next one is ECG monitoring if indicated. CCBs can affect cardiac conduction. Therefore, monitor rhythm, especially in patients on IV CCBs or with arrhythmias, in order to monitor their heart conduction. So now we're going to talk about the nursing considerations during and after administration. So first is we have to monitor vital signs to assess drug effectiveness and detect adverse effects early. Check the blood pressure and heart rate regularly, especially after dose changes. The second one is to watch for side effects. Hypotension from vasodilation, bradycardia especially with verapamil and diltiazem, peripheral edema which is commonly with amlodipine, constipation notably with verapamil, and we have to monitor symptoms and notify provider as needed. The next one is to initiate patient education. This is to promote safe medication use. First one is to teach the patient to change positions slowly to prevent dizziness. Avoid grapefruit juice, which could alter drug metabolism. Instruct not to stop abruptly, and report signs of heart failure or arrhythmias. So next one is IV administration if applicable. Rapid effects require close monitoring. Therefore, we have to administer slowly and monitor ECG and vitals. And the last one is to evaluate therapeutic effect. This is to determine if the medication is working. Monitor for decreased blood pressure, relief of chest pain, or rate control in arrhythmias.
In conclusion, CCBs inhibit calcium influx into cardiac and vascular smooth muscle, leading to vasodilation, reduced heart rate, and decreased myocardial oxygen demand. It has two main classes. Dihydropyridines act mainly on the blood vessels, while non-dihydropyridines act mainly on the heart. It is indicated for hypertension, angina, and certain arrhythmias. Some important considerations is to monitor for blood pressure, heart rate, and for signs of heart block or heart failure. Watch for interactions, especially with grapefruit juice and other cardiac drugs, and educate patients on side effects and adherence to therapy.